Hi everyone, so today's video is going to be about aspirin, and so by knowing the mechanism of aspirin, we can figure out exactly why we're going to use it and what are the potential side effects that could occur, as well as the contraindications. So aspirin, right, sometimes called acetyl salicylic acid, is going to primarily target the cyclooxygenase enzyme. Aspirin is a non-steroidal anti-inflammatory drug, okay? And the reason I say that is because, again, corticosteroids are steroidal anti-inflammatory drugs. So this is a non-steroidal. But there's a lot of different medications that fall under this class. There's drugs like diclofenac, for example. There's indomethacin, there's celecoxib, right? There's ibuprofen. So again, we're not going to go through all these, but it's important to note that these medications are reversible inhibitors. We can reverse the inhibition of the cyclooxygenase enzyme with these drugs. What's unique about aspirin is that it is an irreversible inhibitor. Remember, we talked about thromboxane A2, and thromboxane A2 has two major effects. The first effect is that it causes vasoconstriction, and the principle behind that was that by slowing the blood flow, we allow more platelets to interact with the subendothelial collagen. The second thing was that this thromboxane A2 then goes on to activate more platelets, and thus it has a crucial role in platelet activation. Okay, so with that being said, we know that this thromboxane A2 is going to be a prothrombus. And you can imagine if I'm a medication like aspirin, right? Aspirin is inhibiting the cyclooxygenase enzyme, so we have less thromboxane A2. So it's going to be antithrombotic because it's inhibiting the conversion of arachidonic acid to form thromboxane A2. And we'll get in the pathway just in a minute. And all this makes it less likely to form a thrombus. What does that mean? That means that I might see an increase in my bleeding time, right? Because I have less platelet activation and less vasoconstriction. When would you want to use this? Particularly a patient that has a history of cardiovascular disease or some concern that the patient is potentially having a heart attack or a stroke or previously had a stroke, as this is just a high-level overview. We'll get into more detail about the medical aspects of this in other videos. But what you really want to be careful with aspirin is if you give it to somebody with a pre-existing antithrombotic defect, as these patients can potentially bleed because you're decreasing the activation of platelets as the vasoconstriction is already happening. The other big side effect that you want to be familiar with is gastric ulcer disease. If we look at this image right here, we can see that arachidonic acid can go under two pathways, one with the lipoxygenase enzyme converting it into leukotrienes, and the other, which we'll be focusing on today, is via the cyclooxygenase enzyme converting it into thromboxane A2, into prostaglandins, and into prostacyclins. And so essentially the prostaglandins will be assisting with bicarbonate release, right? And checking and making sure that gastric acid levels are equalized along the surface of the gastric epithelium. So if I decrease my prostaglandins because I'm giving a patient aspirin, which inhibits this pathway, okay, what that does is you end up having a higher acidity of the gastric acid along the gastric epithelium, and that can lead to ulcer formation. So not only are you inhibiting thromboxane A2, causing the bleeding time to probably go up, but you're also inhibiting prostaglandins, leading to gastric ulcer disease. Another side effect is tinnitus, also very classic, as aspirin can cause damage to the vestibulocochlear nerve, and you can also see kidney injury potentially also, especially if the patient is on aspirin for a long time. You can also see some allergic reactions to aspirin. When we talk about aspirin, we should never forget to talk about Reye syndrome, and essentially what this is a hepatic encephalopathy in children that have had some kind of viral illness. So the point is, if you have a pediatric patient that has a fever, you shouldn't be giving them aspirin. And part of the reason for that is whenever these children have a viral illness for whatever reason, they end up with a toxic level of salicylates from the aspirin in the liver. And so it builds up in the liver and causes mitochondrial damage, and that leads to decreased hepatic ATP production. Ultimately, the big point you want to remember is that this causes hyperammonemia, and the levels get very, very high. So what you'll usually see in these patients because of the liver disease is that they'll have an acute increase in the AST and ALT, right? their ammonia levels will be high, like we just said, and this will lead to findings like asterixis, for example, in the setting of this encephalopathy. So this would be all very classic. And the reason we talk about Reye syndrome, even though it is potentially rare, is that the mortality rate is high, ranging from 30 to 35%. The presentation is usually vomiting, agitation, lethargy, restlessness, and we diagnose it with the hyperammonemia, as we mentioned, the prolonged bleeding time, hypoglycemia, and extensive fatty vascularization of the liver. How do we treat it? We give glucose with fresh frozen plasma and mannitol to decrease cerebral edema. Potential complications include fulminant hepatic failure. Point being, you don't use aspirin in children with fevers because you're worried about this whole Reye syndrome. Now, there's only one exception to that rule, okay? The exception is going to be Kawasaki disease. And in Kawasaki disease, typically aspirin is going to be in the realm of possibilities, even in a child. And that was a quick overview on aspirin. Thank you very much.